the right portal vein, clear the left lateral lobe of tumor, and now you have a situation, you have already dissected the parenchyma, you have divided the right portal vein branch, so there's much less perfusion of the right liver, which is supposed to come out anyway. You still have arterial perfusion. And if you do that, what happens is very interesting. So that's how it looks like in surgery with a malperfused segment 4 of the liver. If you do that, within about a week's time, the left lateral lobe increases in size very much. So there is a very strong regeneration of the left lateral lobe. And if you look at it statistically, you get a basically 100% increase in volume and also in function of that too small left lateral lobe. So in the second operation, then about a week later, you can remove the extended right lobe, which has shrunken a little bit, and leave the hypertrophied left lateral lobe. And by that you can make tumors resectable that are otherwise irresectable. That's the case of a younger patient with an adenocarcinoma of the sigmoid, synchronous bilateral liver metastasis. The patient first underwent 3 courses of chemotherapy. The tumors became smaller but still required an extended right hepatectomy. The functional residual volume of the left lateral liver was 142 milliliters, which was far too small for the patient for survival. So in the first surgery we did this, what I just described in the schemes before, an atypical resection of the left lateral lobe and an in situ splitting of the liver and takedown of the right portal vein. And within a week's time there was an hypertrophy. Now it was 440 milliliters. So in the second surgery we removed the right liver and also did an oncologic resection of the sigmoid colon. 7 days later the patient would go home. And the patient recovered well. So this shows you can make unresectable tumors in the liver resectable by different means. Another question is when you have a small tumor, like here, the small colorectal metastasis just between the middle and the right hepatic vein. The question is, should you do a right hepatectomy by which you can remove the tumor easily, or should you do a parenchymal sparing resection, which may be technically a little bit difficult because you are just between the right and the middle hepatic vein. And in fact, what we did in this case, that's the intraoperative ultrasound, that's the standard ultrasound, no contrast enhanced, and you can see the tumor nicely. You see the vena cava inferior, you see the middle and the right hepatic vein, and in this case, we decided to do a just local resection. This means that you basically expose the right and the middle hepatic vein. That's the resection specimen, and it was a complete resection. So there are also data showing that if you do this liver sparing surgery for small metastasis, in the long term the results are better, not because the rate of recurrence is lower, but if you have still more functional liver mass, you have more options to do surgery for a second time or to do tumor ablation for a second time. So parenchymal sparing surgery, and again for that you need intraoperative ultrasound for optimal localization. This brings us to very extensive tumors. So if you look at this picture, and the surgeons among you, would you suggest that this is a resectable tumor? The right hepatic vein, the middle hepatic vein are clearly in the tumor. The left hepatic vein is also basically in the tumor, or at least compressed by the tumor for about 2 or 3 centimeters. Here you can see the tumor, if you go down in the CT scan, the middle hepatic vein just entering the tumor there. and the infiltration of the biliary bifurcation. You see cholestasis in the left lateral lobe of the liver, which is already very much hypertrophied spontaneously. And in fact, we did a resection of that. Histologically, it turned out to be an alveolar echinococosis. And what we did is basically do an extended right resection with resection of the hepatic bifurcation and also resection and reconstruction of the left hepatic vein for about 3 or 4 centimeters with an end-to-side anastomosis of the left hepatic vein to the vena cava, and the patient has recovered from the surgery very well. So in terms of, before I come to say a few words to transplantation, to sum up for the optimal treatment of liver tumors, individual evaluation of chances and risks by an experienced liver surgeon always has to be done in patients with liver tumors. Frequently, if they are just seen by a medical oncologist, they may be referred just for palliative treatment, although they might be potentially resectable. So an experienced liver surgeon needs to see them. You need to do adequate diagnostics in order to avoid inappropriate surgery. You have to do an interdisciplinary planning of the therapeutic strategy. Surgery needs to be done by an experienced liver surgeon in a center where you have the whole technical toolbox available for treatment. You can also use, I didn't go into that, innovative techniques for ablation like irreversible electroporation. And you need individually oncologically optimized concept for each individual patient in order to achieve excellent long-term results, which may also include re-resections or re-resections to remove recurrent tumors. So a few words coming to another topic of the liver, to liver transplantation. Liver transplantation, as you all know, depends on available donor organs. And worldwide, the majority of transplantations is done with transplantation with organs from deceased donors. And what you see here is the organ transplantation rates in Europe. And you see that Germany is basically at the absolutely lower end of the organ donation rate, and almost all other countries in Europe have better organ donation rates, which creates a relevant problem. If you have too few organs and many patients waiting, how do you do the organ allocation? And particularly for the liver, which is an organ you need, you cannot replace it by a machine. It's the selection of which patient really to transplant. And it's not only the numbers of donors which are very low, it's also the type of donors which has changed over the last 20 years. It's no longer the 20-year-old motorcycle accident victim who is a liver donor. Usually it's the 75-year-old with hypertensive intracranial bleeding. So the average age of liver donors is around 60 years, which also indicates that the quality of organs we have available for transplantation is much, much worse than 20 years ago. We have a lot of fatty organs, we have patients with severe atherosclerosis, but we still have to use these organs because frequently these are the only ones we have. The allocation in Germany is done by the so-called MELD score. This means the higher that score, the more ill the patient is. And since we have a shortage of organs, basically all organs go into very, very ill patients, which leads to the fact that nowadays the results of liver transplantation in Germany are much worse than 20 years ago. Because in the end, we transplant the wrong patients at the wrong time point. So that's the types of patients we do liver transplantation in. They are on ICU prior to transplantation. They are on hemofiltration because of secondary renal failure. They are extremely sarcopenic. And of course, if you do a big operation in such a patient, you will have quite a lot of complications, infectious complications like fungal infections, aspergillosis, and the patients recover very slowly because they have no muscular mass anymore. So what can you do to solve the problem of organ shortage? One is to do splitting of donor organs. Like in this case, you can use one part, here the right extended lobe for an adult, the left lateral lobe for a child, because the anatomy of the liver really allows to split it into two parts that then can be transplanted. But misfortunately, this only works quite well if one of the recipients is a pediatric recipient, because for those you can use the left lateral lobe, and the right extended lobe is usually sufficient for an adult. To do a complete anatomic left-right split is rarely done because it increases the technical complications and also the complications for both recipients. So usually we do this back table preparation, and in the end this is the left lateral lobe. It looks the same like the left lateral lobe after a living donation if you do left lateral transplantation for a child. And this left lateral lobe, here you see it after transplantation in a child, may even be too big if it's a small child, so you have other technical problems of abdominal wall closure, because if you have small children with 4 or 5 kilograms body weight, even a 200 gram size left lateral lobe may be too big for these small children. A very specific transplant we did now, I think more than 10 years ago. We had a donor organ from a 9-month-old donor, so a pediatric donor, and we splitted this organ, and the left lateral lobe with, I think, 90 gram went into a 2.7 kilogram child with an acute liver failure. This is both patients about a month after transplantation, and the extended right lobe of the pediatric donor into a 1-year-old 7 kilogram patient with alpha-1 antitrypsin deficiency. And actually I just saw the patient on the right. He is now, I think, 16 years old and plays soccer with RB Salzburg in Austria. So he's the same professional soccer player. So you can see that the long-term results of these procedures are really very good. Actually, both patients are doing very good. Where we use AI or advanced technical methods is sometimes to assess the liver anatomy, but if you scroll through a CT scan, an experienced surgeon usually has all of these things in his mind and does not necessarily need these techniques. So I jump over living donation advantages, disadvantages. That's a living donation of the right lobe of the liver, for example, after transplantation, and come in the end to a technique that we are also doing sometimes now in specific situations, which is called auxiliary two-stage partial resection and liver transplantation. So if you have a patient with a liver cirrhosis, so this should be a cirrhotic liver, and you have a donor or a part of a donor organ, say of a living donor, where you want to keep the risk very low and just take the left lateral lobe. Because taking the left lateral lobe is a very low risk for the donor. It's a rather small operation. But this part of the liver would not be large enough to transplant that patient. So you can do a two-step procedure. You resect the left lateral lobe of the cirrhotic liver, place the left lateral or left transplant, which is basically too small, do an end-to-end anastomosis of the left hepatic vein, reconstruct the artery, do a hepatocejejinostomy to reconstruct the bile duct. And if you then, like in the ALPS procedure I showed you before, if you then wait for about a week or 10 days, this graft hypertrophies about 100%, and the function also improves very much. So like in the ALPS procedure, in the second operation, you can then remove the rest of the cirrhotic liver, because the cirrhotic liver should come out because it's a precancerous, tumors could develop in that. Just shortly show you slides of a patient. That's the recipient with an autoimmune hepatitis. That's the donor. And you see the left lateral lobe is rather small. So of course, you do volumetry in order really to find out which part of the liver is exactly what size. The patient was a recipient, was a 30-year-old female with autoimmune hepatitis, and here you see a CT scan 2 days after that surgery. On the right side, still the cirrhotic liver. On the left side, the actually too small graft. And 12 days later, you see the graft has hypertrophied considerably and was now sufficient to support the life. So in the second operation, you see the volume has more than doubled during that week. In the second operation, we have done the completion hepatectomy, and the patient survived well with the graft, and still a couple of days later it was 900 milliliters, so it has further increased in size. Post-op, of course, was quite uneventful. So what's still new in transplantation, but I can jump over that, machine perfusion. We don't do that very frequently, but there are others who can tell you more about the option of normothermic oxygenized machine perfusion. So to end up, take-home message for liver transplantation, at least from the view in Germany. We have a very low post-mortal donor organ numbers. We have more and more older and marginal donor organs available. We have, in my view, inappropriate organ allocation policy. We transplant too ill patients, and this leads to rather bad results. Liver splitting is possible, but rarely done, basically only when you have a child to transplant. Living donation is an option, mostly used for children. In Germany, rarely for adults. But there are new techniques for living donation, like I've showed you, which are safer for the donor, but are riskier for the recipient because it's 2 surgeries the recipient has to undergo, and it's technically more complex. And finally, we have the options of machine perfusion, which I did not go into detail. So thank you very much for listening. We always have to think about new ideas how to develop the field. Thank you very much.